asking me to come. And thanks to Dr. Ahmed for a really interesting talk. I think there's going to be a lot of common themes and overlap in terms of navigating the transition between paediatric and adult care. So hopefully our two talks will complement each other. I'm not going to dwell too much on the actual medicine. I think, as Dr. Ahmed said, ED and GP are generalists, not specialists, so I think there are people better placed here to talk about the ins and outs of specialist TOF care. What I'm going to try and aim to do is pick up on some common themes from the Adult TOFs conference that was held in June of this year, and sow some kind of thoughts, sow some seeds for how we as patient groups can drive our care, especially as adults or for those older paediatric, younger TOF adult patients in need of onward care, and how we can do that as a group together. So very, very briefly, my husband's here. I don't think he said, are you going to talk about your cough that you always have? I was like, maybe. So I was born back in 1983, back in London, had a TOF OA repaired within sort of 6-7 hours of birth. ASD, VSD was repaired about 18 months. In and out of hospital till I was about 14, and then fortunate enough to be pretty much discharged. Carried on, it hasn't really impacted too much. I have a cough. I have to remember to drink lots of water when I eat to avoid choking in a car park outside work. But apart from that, active, working, and now I split my time between helicopter emergency medical services and A&E at Croydon, which is interesting. So I thought I want to put in context how we've come as an adult TOF community. So I sort of look back to see the first reports of adult TOFs, as it were. Back in 1935, a baby born without esophagus made headlines in the US. Then there was the trips to try and fundraise to fund his care, which I think we're lucky enough not to have to deal with too much within the NHS. Being baptised in hospital, I think a lot of us can relate to that. And then a whole article about his repair, probably 1936. And then this slide, this bit at the bottom, the same doctor, 1996, saying he hasn't seen his child for over 30 years, but actually he's doing really well. And that was the first documented adult TOF onward research I could find. Then briefly in 1987, again, the ins and outs of this don't matter so much, but this was 300 patients, of whom about 150 were adults. And it basically is sort of a slightly onwards, looking at how they progressed through childhood. Very little research into adulthood, because not many of them were adults. The common problems to all of us, so feeding, chest problems, a bit of lung function problems, and then the main impact on how that impacts on our education, how that impacts on whether we're able to play sport, go for walks, and our daily life, sort of marriage, children, onward problems. But again, most of the children in this were still under 5, so very little onward work into adult care. And that brings us to June of this year, which I think was the largest, or first of its kind, the largest number of adult TOFs in the UK in any one place. Representation nationally, all ages, all spectrums of severity, all coping with slightly different challenges. Seems to be a slightly female predominance, but I don't know if that's just the group here. And it was a great opportunity to share stories, experiences, and coping strategies for day-to-day life, and that transition from being a paediatric TOF to being a young person with TOF to being an adult with TOF. So we kind of talked about what went on that day. There were 6 adult TOFs who spoke about their experiences, spoke about what they'd experienced as paediatric TOFs, how they'd then gone into adult care and how that affected them on their day-to-day life. Some people were more affected than others, but I think there was a common theme of wanting to share that experience to help others. Then Mr. Gossage talked about the association between TOF OA and Barrett's esophagus, and I'm not going to dwell too much on this, but there is talk about whether there should be screening for Barrett's esophagus in the TOF paediatric and adult population. But again, there's not enough known about long-term outcomes because there's not enough known about long-term adult TOF OA. Dr. Wallace, who's here, talked about psychological aspects and well-being, which I'll touch on briefly. Prof. Morris talked about the TOF cough and aspiration, and whether the cough was more a result of having reflux and then aspirating, causing a chemical pneumonitis, rather than it being purely infectious, which is food for thought. And then group discussion. I think the themes that came out of that, and I don't want to kind of alarm anyone or kind of cause despair, but I think it was quite interesting to get a group of adults who were quite outspoken in the same place and all managing really well on a day-to-day basis, but they still had these frustrations, which were common to greater or lesser extents with everyone. So Dr. Ahmed's already talked about sort of that transition from paediatric to adult care and that frustration, apprehension, what does that mean for me, what does that mean for my parents, siblings, child? I think there was a big sort of statement that just because you've had your TOF fixed, it doesn't mean everything's okay. And just because you've been discharged from the surgical side of things doesn't mean there aren't any challenges. So a greater appreciation by generalists such as ED and GPs that actually, yes, you know, your TOF might have been sewn up when you were 6 hours old, but you still have to be careful when you swallow. You have to be careful what you eat. You're still having reflux. You're still having breathing problems, and how to manage that. We talked briefly about the lack of follow-up and lack of long-term follow-up, which I'll come on to later. And I think there was a talk about how to re-access the system. So once you have been discharged and you've maybe moved from, I don't know, I might have moved from London up to Edinburgh, how do I re-access the system? Who do I go to help me access that system once I've started having sort of different problems or different challenges? I think Dr. Ahmed has talked about the lack of general medical professional awareness of TOF OA, not Tracheo-Oesophageal Fistula, let alone the challenges faced as an adult. And I think paediatric surgical trainees rarely see TOF. So, if you're a paediatric subspecialist surgical trainee and you're not really seeing TOF OA, how can we expect the rest of the medical profession to really have more than just a general understanding of what that entails? And then there's onward plannings of perhaps we could drive forward the need for a collaborative, shared, central registry, and sort of regional-led, multidisciplinary. You've got dietitians, you've got physios, you've got surgeons, you've got doctors, you've got nurses to coordinate that care for the adult TOF and for young adult TOFs. So we talk quite a lot about transition. Transition is a kind of system or a plan to carefully move someone across from a system where they know the people looking after them, they're looked after nationally or regionally, very child-centred, very family-centred, suddenly to a more adult-oriented, where you're supposed to be able to look after yourself and speak for yourself, and you don't see the same person every time, you don't necessarily see the same consultant you grew up with, they might have retired, they've passed, they might have passed on. So it's a very kind of different system to work in. Transfer, moving from one hospital to another, but actually it's more than just a change of hospitals, it's more than just a change of location. And that might arouse, apprehension, you don't want to do it, tears, frustration, nerves, which are all perfectly normal reactions to moving from one system of care to another. So I think there was enough emphasis or awareness about this that NHS England back in 2014 asked this Care Quality Commission to investigate what could be done better to enable people with chronic ongoing challenges and illnesses to transition between paediatric and adult care. It can be done. There are really good examples from the CF community, from diabetes, from congenital cardiac disease. There's really good transition from paediatric care to young adult care to ongoing adult care. But they need a framework. And I think we've talked briefly about some of these. So a documented transition plan, that coordination between secondary care, between tertiary care, and between primary care. A health passport, so some way of having a central repository of the information for you, for your child, for your family, for your carers, whether that's formal or informal, so that all the different people involved in your care can have access to that information. It doesn't rely on you, it doesn't rely on any one person, but you've got a centralised piece of paper or pieces of paper. One individual who's in charge, whether that's your GP, your social worker, your carer, your nurse, your dietitian, someone who is responsible for coordinating that move and that onward care. Dr. Ahmed's mentioned about GPs, getting a note when you're 16, 17, 18, saying, oh, this person's been discharged. They've never seen them. They've all been looked after on a secondary or tertiary level. So actually involving GPs much earlier, and as parents, as siblings, as family members, trying to get your GP involved earlier so that when that time comes, when your child is needing to go on to adult care, the GPs know who they are. They've seen them when they're well. They know what's normal. They know what's not normal, and are able to advocate for them in a more sort of informed manner. Transition is important for a huge number of reasons. Psychologically, educationally, from a sense of isolation and from a sense of looking after each other as families. There are numerous papers which document the benefits of having a really well-managed transition programme from paediatric to adult care. There are also healthcare benefits in the sense that if you know where you're going and you're wanting to go there, you're actually going to go to your outpatient clinic. You actually know where it is. You know who you're going to see. So you don't have that drop-off in attendance. And that in itself has benefits in terms of you don't end up in hospital because you haven't been to your hospital appointments because you don't know where they are. But that needs time. It's a big, big change to go from a system where you trust, you know your consultants, you know their registrars, you know the nurses on the ward that you always go to actually being in a different community. So you need time to engage with them and get to trust them, and they get to know you and you know to go. So this doesn't happen overnight. This happens over weeks, months, years, while you slowly start to transition between the two. particularly with TOF OA, I think the main thing to get out of this slide is it's multi-system. It's not just your tummy, it's not just your lungs, it's not just your swallowing, it's not just your limbs that don't work quite right. There's multi-system things going on, and it needs a multi-system or multidisciplinary approach. And I think that's partly where the healthcare system comes up slightly short, in that we think of specialists, so you go and see your respiratory doctor, you go and see your GI doctor. But actually, I think with TOF OA, you need more of a multidisciplinary approach, and that's something that we should work on as a patient group to try and advocate for down the line. And again, there's this feeling that it's not just restricted to surgical problems. You've seen your paediatric upper GI surgeon, but your ongoing problems might need to be seen by a respiratory doctor, or by a GI doctor, or by both, or by all of them. But again, it's a multidisciplinary approach. This is a hot topic, and I'm sure there are people far more qualified to talk about it than I am, but should there be routine follow-up for all those with repaired TOF OA? Now there are more adults, we're surviving later, we're doing well, we're doing everything normally, as it were, but do we need surveillance to check whether we're developing Barrett's esophagus? And again, there's lots of debate about that and different ways of practicing. So I just had a brief look about what other countries do, because I think the best way of learning and not recreating a wheel is seeing what other people are doing and doing well. So over in Melbourne, and these ideas are shared with permission, at the Royal Children's Hospital, they're developing a whole transition service for TOF OA patients. They're writing fact sheets, educational resources for parents, families, carers, and local GPs. And these were the key messages. They sort of said that they are happy for me to share, that they feel that follow-up does need to be lifelong. You need ongoing care with a gastroenterologist, even if you feel that actually you haven't got a huge number of symptoms. Their protocol is endoscopies every 4 years. But again, I think this is key, linking in with your good local GP services so they know you and they can manage your care. This is their pathway, and again, the names are irrelevant, but it's just that they have a pathway. It starts when you're still paediatric, so it starts when you're young. Then you go to a transition clinic, you're managed in joint care, and then you're gradually transitioned over to a person who you know who they are and where that is. So you're more likely to go, you're more likely to talk with them about your problems, and you trust them. And this is their follow-up plan. Again, I don't know if this is right, wrong, different, but it's interesting to see this is what they do and the ages at which they do it. And it gets sort of more frequent as you get older. So as there are more older TOFs, perhaps this should be something we consider. They're also doing a research study, which is run by the transition manager, which again will be quite interesting down the line to see how patients and carers engage with transition and the long-term outcomes of paediatrics and young adults living with TOF and OA. And this is a long-term, longitudinal project, so I don't think the results will be out for a while. But again, it will be quite interesting to see if that comes up with any new ideas, either medically, psychologically, or sort of structurally as to how best manage. This is what they do in the Netherlands. Really busy slide, don't expect you to read it all. But essentially it's saying it goes from 5 months all the way through 18 years and on, and the number of different specialties involved. So this is the Erasmus Children's Hospital in the Netherlands. But it's just illustrating the fact that it's throughout the whole time, it's the same people, but it's, you know, you've got a psychologist, you've got lung function people, you've got geneticists, you've got endoscopies, you've got nurses, you've got paediatricians. It's not just a one-system disease, and it needs multidisciplinary support to manage that care. I think Dr. Ahmed alluded to this a bit, in a sense that I think as patients, once you get older, you need to advocate more for yourself. And whether that's you're being transferred over to adult care or being discharged, having a mental checklist of things that you might need to talk about and might need to know yourself so that you can tell your doctor when you see them or when you go to ED. That most ED doctors will never have heard of TOF OA at all, and I'm speaking as one of them. So actually being able to educate doctors when you see them. And this is just, I mean, it's not an exhaustive list, but it's some things that popped up and that they use in Melbourne as things to sort of make sure that you know about, and things that you make sure your child knows about, you know about as carers, that you can actually talk for yourself, or if you don't know where to ask or who to ask. And again, you have a general practitioner that you trust and feel comfortable with. And that's, I think, a key thing, and I don't know if we yet have an answer to that. Dr. Ahmed briefly talked about kind of health passports or communication. I think this is a really amazing concept that was started for people with kind of learning disabilities and much sort of more chronic health needs. But essentially, it's at one place, having everything in one place, using to coordinate care between all the different professionals and having everything in one place. I think I was talking to Mum and I was like, what exactly did I have when I was, you know, six hours old? She can't remember. The records have been destroyed because I'm over 30, and the person who looked after me has retired and moved to another country. So I actually don't know any of this now. But if you start thinking about this when your child is young and collecting everything in one place, you can then take that if you move abroad, if you go on holiday, if you move to a different part of the country, and have it as a central place for a multidisciplinary approach to your child's care. Dr. Wallace talked about psychological well-being, which is becoming more and more an important part of integrated patient care. Support for parents, support for the children. I think you had a really nice phrase, they're ordinary children doing extraordinary things. And I think that's a really nice way of doing it. And we need to enable them to overcome the challenges they face. I don't think this has come through, but it was Jade, who I'll talk about later. Her sister gave her this when she went off to university, saying the best way to not collapse is to rest and don't push it. And I think that's really good, mindfulness and really good advice that we should all take. But essentially, it's sort of talking to families about how they can support their child, talking to their child aside from their illness, making sure you're looking after the sibling of that child, making sure you're allowing time for yourself, both as a mum or a dad or a carer, and you as a couple, so it doesn't all become all-consuming, which is so easy to do when you're in hospital the whole time. And then as people move on to adolescence and adulthood, how to cope with scars, how to cope with feeding tubes, how to cope with difficulties swallowing in public places, and having behavioural techniques and coping strategies for managing that. So it's not just about the medical, it's about the psychological as well. So moving on to the final bit. So Jade, this is Jade. She's qualified, I think, earlier this year, and she's a paediatric nurse. She's also an adult TOF. This is Jade wanting to be a nurse. This is Jade now being a nurse. And I was speaking with her about doing this talk, and she has suggested some tips for coping with transitioning from paediatric to adult care. This is actually what she did her dissertation on as part of her nursing degree. So I think her thing was saying having conversations early. Don't wait for it to happen. You are going to turn 18 at some point. So it doesn't suddenly happen. You know when you're 6, when you're 8, when you're 10, when you're 12, that your child is going to grow up. They might not need any more onward care. They might need onward care. But start to think about that earlier. Once you've got over that initial, gosh, this is all overwhelming. But once they're in a stable place, and as a family you're in a more stable place. Be realistic. It's not all going to be plain sailing. It's tough being a teenager anyway, let alone a teenager with swallowing problems or with constant chest infections and you're in and out of hospital and missing school or you've got scars. Other people have done that, but don't pretend it's all plain sailing. So just being honest that it's okay to not be okay. I think autonomy is really important. You're in hospital the whole time. Everything is micromanaged. Your meal times are micromanaged. When you get woken up to have your obs done at 5 o'clock, it's micromanaged. So actually having a little bit of autonomy about when you do stuff and how you do it is really, really important, both psychologically and in terms of gaining independence when you're in hospitals the whole time. And again, if there's any sort of element of cognitive or neurodisability, those choices don't have to be big choices, but a certain element of self-autonomy is really important for children. I think from a medical perspective and from a parent's perspective, asking sort of both young people and their families what they want and giving the opportunity to ask questions. I think as a medical professional, often we're getting better, but it used to be a very one-way street. But actually, it's a shared decision, as Dr. Ahmed said, it's shared decision-making. So make sure that you are given the opportunity to ask questions, and as doctors, that you give those young people and their families the opportunity to ask questions. And we've talked about this need for greater collaboration between primary and secondary care. So if you're a hospital specialist, making sure you update the GP of that TOF child, not when they're just about to be discharged, but 6 years before, 4 years before, 2 years before. It doesn't have to be great reams, but just a bit more than is currently practiced. And as we said, it's a gradual process. We know you're going to get to 18. Make sure you're prepared for it rather than suddenly going from a lovely, warm, cozy environment where you know everyone looking after you to suddenly feeling a bit lost. And I'm rubbish at technology, but apparently there are lots of apps to help patients monitor and manage their conditions. So if you're into that kind of thing, there are lots more apps so you can be more self-aware. I mean, there's feeding apps and all those kinds of things, but they carry on once you're older. I think support groups are really helpful. I think there are various aspects of them which people draw on at different times. You don't have to use them the whole time, but if you're feeling frustrated or challenged, someone else has probably felt that. So making sure you reach out, whether that's online, forums like this, loads of different ways. But people have been through it before and people have other ways of strategizing. I think the overall theme that Jade had was that each young person is an individual. There's going to be no one right way. There's going to be no one right person for each family, for each caring setup. But make sure that you treat them as individuals. They're going to be going through a lot with adolescence, with going to university, with going to school, changing from primary to secondary school, just like any normal young person. But they've got added challenges of, as we've spoken about, feeding challenges. You might have a gastrostomy, you might have scars, you're dealing with relationships for the first time. How much do you tell them about your TOF cough that you always have? There's lots of different issues that children are going to have and young adolescents are going to have. But even if your GP doesn't know where or doesn't know all the answers, they will be able to signpost you to the right person. So make sure that it's not just about the medical things that you can approach your GP. And I think we've mentioned this, a key worker for transition, or one key person, and it doesn't have to be your GP, it could be your consultant, it could be a specialist nurse, it could be your dietitian, psychologist, psychiatrist, but having one person who you feel you can approach, who can direct you to places that you need, and who has a general overview of you and your sort of TOF OA and associated conditions. So I think the take-home points that I got from the Adult TOFs forum were that there is a huge variety in ongoing health challenges. Some people have lots of need for ongoing care, some don't. But those who've been discharged need to have access. Those who need ongoing care need to have that ongoing care done in a centralised way. I think the problem at the moment, there are so few TOF adults who are in need of ongoing care that actually a regionalised setup might be better. So whether there should be a regionalised adult multidisciplinary group, much like the one in the Netherlands, but we need to drive funding for that. It's not free. We talked briefly about money. Everything does need to be paid for, but there needs to be patient-driven demand for that. And then you can start looking at outcomes and ways to best manage things. I think for ourselves, we are kind of the experts in your own condition. So you kind of have to think of yourself as you get older of being the expert patient slightly and making sure you can answer those questions. And if you can't, ask your specialist the answers to them. And then you used to kind of centralise documents to facilitate care. Really important to manage that transition between paediatric and adult care well for both patient and healthcare reasons, and a link with a GP before discharge or transition to ensure that there is coordination of care and cohesiveness. And we've talked about ongoing research so that actually we can do all of this much better. The more we know, the better we're going to be able to do all of this. So those are some of the people who helped with this, and thank you very much.
Harriet, thank you for a fantastic presentation. Really interesting and very helpful. We can take questions from the floor very briefly before lunch. Just a couple of questions. Yes.
Hey. Hey.
We've been discussing in our department how we manage transition. How far would you and other audience members be happy to travel for specialist-informed adult care?
So I think, and I don't want to speak for people here, but the feeling from the adult group in June was they would literally be willing to travel the whole country, just to have access to informed care, someone who knows what's happening, and the other allied health professions. So there was, yeah, I don't think distance was an issue, as long as you know when it's going to be. So it's not tomorrow. Yeah.
Thank you.
We've gone miles, yeah. I've interviewed surgeons and people, and if I wasn't happy with them, then I'd say, thank you very much, sir, we're off, and we'll find someone that does know what they're on about.
Okay, we'll have one last question from the back.
Hi, I'm Claire, TOF mum. A lot of your presentation you talked about psychological input or the use of psychologists, and I wondered how many of your adult TOFs had access to that when needed. Myself being a psychologist, kind of interested in that, because I know it's probably quite rare.
So again, Dr. Wallace might be better placed. From my personal experience, none. But I think there is a move in healthcare generally. So what is sort of 30, 35 years since I was in and out of hospital the whole time. So I think there is a greater emphasis on the important aspect of psychology and resilience and all those, and self-help. So I think it's become less of a luxury and more of a mandated aspect of healthcare, both for patients and their families. But I think, again, it comes back to funding and getting a model in place where that is possible.
Yeah, I think, again, it depends what kind of region you're in, and authority is quite variable. But in my experience, quite limited, unfortunately.
Yeah, I would agree, yeah.
Thank you.
Great, thank you very much indeed, Harriet.